I'm Grady Culhane in the CapeCod.com News Center, joined today for a special segment about health. We want to talk a little bit more about a new, less invasive procedure when it comes to treating enlarged prostates. Actually, we have a large demographic of Cape Codders who are older gentlemen, so this is something that is going to pertain to a lot of our listeners. But yes, doctor, do you mind just introducing yourself for our listeners, telling us a little bit more about yourself and what your official title is?
Yeah, thanks, Grady, for having me on this. Appreciate it. My name is Dr. Shams Iqbal. I'm an interventional radiologist by profession, and I work at Mass General Hospital. I'm a senior staff radiologist there. And uh, by IR, we mean it's an image guided surgical field, which is a very niche field where we are not related to an organ system. We are bound slash married to a technique, which is image guided procedure. And that opens up the whole world for us. We can treat a myriad of issues, situations, diagnosis, and treat them with minimal invasion. For example, the most common being cancer, and then as we are going to talk about prostate and other issues, with least invasion to the extent that the patient get discharged within hours after the surgical procedure.
Wow, that's a huge cut down on time. That is wonderful. So yeah, I'd love to talk about the cancer stuff as well, but just starting off with what is the different? How does this help out? Can you tell us a little bit more about the procedure involved, and how for especially the enlarged prostate? I know that it can get very invasive and it can lead to a lot of recovery time. What are some of the ways that you've been able to help cut down on that? Can you give us a light description of kind of like how it works and what the
Yeah,
benefits are?
that's perfect. So, uh, you know, prostate is an organ which is a part of the male population, and we have this by virtue of being male, and also the predominant hormone in the male is testosterone. So over time, the prostate gets acted upon by the testosterone, and it starts growing right from childhood, keeps growing, and by 40 years of age, we start feeling the effect. What it does is like it hardens the prostate, and the tries to regrow. It becomes nodular instead of being a smooth organ. It becomes a nodular organ. So it's placed very strategically in location right underneath the bladder. So the bladder outflow has to go through the center of the prostate. So when it becomes hardened, it becomes nodular, it starts compressing upon the urethra. And that's what leads to all the problems which we like older patients feel. And the most common being like they can't pee properly, they have to pee every now and then, they wake up in the night, which is nocturia. It's a gamut of like seven sign symptoms which leads to things known as lower urinary tract symptoms. So as you might think that the easiest way would be to go through the urethra and uh, take some pieces out. This is what is done in TURP, transurethral recession of prostate. Urologists go through the urethra and then they take pieces out. The caveat of that is like, first of all, it's a much more invasive. Second is like right at the junction of the prostate and the bladder, there are nerve endings, which is what is the primary nerves which which supports our erection and ejaculation. So the one in four patients, again, literature says that one in four patients will lose their erection post TURP. So that's a big problem. So even urologists have thought of this, like trying to find a different kind of procedure where they can avoid this. They call it minimally invasive surgical therapy, MIST. However, like anytime they have to treat it, they have to cut open things. And the moment you cut, the nerves are in danger. The second bigger treatment is like when they go in and they just take the whole prostate out, but it's a much bigger surgery. In this day and age, I don't think anybody should be doing prostatectomy in the setting of benign prostate hypertrophy. That's not a good serving to the patient. What we do is like we came from the other side. As I said, we are not listed to an organ system. We have a technique. We do vascular procedure where we go into the vessel system and we go to the vessel supply of anything, be it tumor and anything else. The same concept. Here, the target organ being prostate. We go and we block the blood supply to the prostate. We can never completely exclude the blood supply. It goes down significantly, like more than 90%, and that good enough to keep the normal prostate tissue to stay alive, and the abnormal ones slowly, because of the lack of blood supply, they slowly recede, and this pulls the central urethra wide open, and your urethral symptoms like significantly decreases, and it's like a very minimally invasive. Yeah, it's amazing.
Wow, yeah, that's very interesting. So it's like you're going through. I once again for the listeners, we are talking about health stuff, so it might get a little squicky for some, but it is so it's through the veins that you're able
through
to
the arteries.
through the
Through the
arteries.
art.
Okay,
Yeah.
that is fascinating. So is there a risk with like cardiac arrest or anything? And normally I hear
Uh,
about like heart attacks being brought on by like blocked arteries, but in this case it's controlled. How does that get avoided or?
yeah. So the arteries which we are concerned about is way far away from the arteries in the heart. The the cardiac arteries is known as the coronary arteries. They are in the chest. What we are targeting is the artery way deep in the pelvis. There's a good 2 feet differential of distance, and and that's why, and this is an older set of population which is affected by this disease. So I try not to go through the radial where you have to cross the chest. I go from the groin, stay in the pelvis. I never see the chest or the upper side vessels. So that's a pretty safe from that standpoint.
Mm-hmm. Wow, that is very interesting. So, do you have? Not to put you on the spot with statistics or anything or data, but like, so there's a lot of successes. Are there risks that it might just not work, or like what's I guess like the worst case scenario in a surgery quote unquote, or an operation like this, a
So
service like this?
I can give you the research data because I was part of the SIR, which is Society of Intermittent Radiology, where we published a white paper like 4 years ago, where we did all the cumulative data for the entire world. Anybody who had published, so there were only out of 2,000 cases done, only there were six issues involved. So this is talking about the complication, and those all the complications were treated without any further surgery or anything.
Hmm.
Regarding the outcome, there are three broad categories of patients who come with prostate. One is enlarged prostate, and all they have is like all these symptoms because of the compression.
Hmm.
Second group is enlarged prostate with hematuria, where they bleed because the prostate is so enlarged, it becomes very juicy. You can think of like a very juicy fruit, and it oozes blood. And significant number of patients come with hematuria. And the way it's managed by the urological world is like they put a catheter through the prostate and they keep washing it, which is very counterintuitive, but they keep washing and hope for the bleeding to stop. And the third group is where patients who have these obstructive symptoms, but again, we try to fight through it. We try to modify our life. We do a bunch of changes, take less alcohol, less coffee, drink less food, all kind of things, which we can just go in details. But however, they reach to a point where they have to put a catheter in them and they live with a catheter. So the success is defined differently in all these three groups. In the hematuria group, if the patient is not bleeding, it's a success. And that in that we are almost 100% successful because all we do is like stop the blood vessel. So it's a very, very intuitive and logical answer. The third group, which I'm going to talk now, is the catheter dependent group. So I have almost 94% success of catheter removal. Anyone who comes with a catheter because of enlarged prostate, I treat them and I do a thing known as a catheter trial. We bring them back in a week, take the catheter out, and ask them to pee. If they can do in a controlled micturition, which is peeing, we don't put the catheter in. If not, we put the catheter in back and we bring him back another week. And I have like very high level of success in that. The third group is which is subjective, where we check them like how bad their signs and symptoms are. We have a scoring grade. We call it IPSS, and we treat them and we check them in 1 month, and they improve almost 78 to 94% range. It's a very high rate of success, and they. But the reason I'm saying this way is because this treatment effect takes about 3 to 6 months to maximize. We see them at 1 month. So initially it's a little lower. Then by 3 months to 6 months, they all almost 96% success rate that their quality of life improved significantly. So overall, it's a very low risk, high gain procedure. The issue is it's a very technically challenging procedure. So you need to have someone who has done a lot because basically in the pelvis we have 8 arteries on each side, and we are looking for the smallest of those arteries because the prostate is a small organ. So that it's about like we're talking about 1 millimeter size vessels, which you have to select in a. It's like a needle in a haystack. So that's the challenge from our side. From the patient standpoint, they come in, get the procedure done. 2 hours later, they're back to home. It's a very efficient. And the last thing which I want to put on this spiel is that if I fail, you have all the surgical procedure at offer. But if you go to the surgical field, it's very challenging for us to go back. Basically, if you're using a small gun to kill a fly or using a cannon to kill a fly. So you start with a gun and then slowly go over to the cannon. So that's the logical escalation, I would say. So if I'm not able to help you, if you're in that 3-4%, you still have the entire surgical aspect which you can approach.
Okay, yeah,
Thank you.
it's very interesting to have the fact that it works as it's not necessarily, well, it is an alternative, but it doesn't preclude the absence of the other potential more tried and true operation if that's necessary. But the success rate, it's very interesting, and it helps avoid some of those unfortunate nasty side effects. And I imagine for a lot of the people, especially who are having to deal with a catheter, a huge improvement in quality of life. So how are there drugs? Can the people drive home afterwards, or do they still have to have? Either way, it sounds like it's a lot less of a problem compared to, say, surgery and recovery time for that. But is there like drugs involved? You said that people have to come back multiple times. Roughly how many times do they have to come back? What does that preparation time for them as a patient look like?
I didn't get the point that like they don't have to come back. They come back as a follow-up clinical discussion. More often than not, I have a bunch of Cape Cod patients, and I do their follow-up on the phone, on the Zoom
Okay.
call, because I don't need to examine them. The procedure on the day of the procedure, we give you sedation so that you're comfortable. It's a painless procedure,
Hmm.
but it's a long procedure. As I said, it's technically challenging, so it takes time. So you need to be comfortable for lying down for like a couple of hours, 2 to 3 hours. So we give sedation, and by law, we cannot discharge anyone with sedation without someone. So you need to come with someone who can drive you home.
All
And I want to plug in one more point here is like, so as I was saying that people try to modify their lives, a lot of people are on medication, which a lot of our listeners will probably correlate easily. There are a couple of medication which is used for prostate enlargement. What it does, like it also leads to that those meds, about 20% of the patient will have impotence. They will not have erection because of those medications, sexual side effects. So again, if somebody is younger, like in their 50s or 60s, they're still pretty active, and it's a very bad, and they go into depression. Like I've seen a lot of patients like, doc, I'm so young, but I'm just not able to manage this. And when we treat, they get off the medication. Suddenly they feel like a different person.
right.
So that's pretty helpful.
Yeah, that is wonderful. Doctor, I'm afraid we're about coming up on time. About covers everything that we have time for right now. But is there anything else you wanted to add for our listeners while we still have you, either about this service or any other exciting advancements in the science?
So we have a lot of advancement, and I can, as you know, I can speak for a long time, but I would just recommend that if you want to talk to me about it and like get a consultation just to discuss the possibilities, I will leave a number that will be the best. My MGH clinic number is 617-726-8488. That will be very helpful. You can call them, set up a consultation. We can talk and figure out, because everybody has slightly different issues and not everyone is a candidate also. So we need to figure out and see if there's help there out there. And I'm happy to help anyone relieve and have a better quality of life. And thank you for having me, Grady.
All right. Yeah, thank you very much. It's been a lovely conversation. I appreciate you making the time for us out of your busy schedule. You've got cases upcoming soon, so we'll draw it to a close. But thank you again for having this conversation with me, Doctor.
Okay, no problem. Thank you. Appreciate it.